Thank you very much for the kind introduction. And I've got my slides. I just need to be able to share them if that's okay. They're fabulous. So yes, my name's Tom. I'm currently a research fellow and surgical trainee here in Edinburgh. And hopefully you'll be able to see my screen. Um, yes, there we go. So today I'm going to talk to you about the current state of AI, a bit of the AI work we do here in Edinburgh, looking at how we can apply AI really for kind of a global benefit of patients across the world and improve surgical care. Um, but also the challenges that that presents to us. And we're really in the infancy of this kind of technology, and there's so much more to do. And it will really transform how we do medicine in the future. And one of the things that I'm going to pitch it at a level that is kind of quite straightforward and understandable, because some of these concepts, when I first started in this area, really blew my mind. So without a doubt, um, it's something that's going to be very important in future. Okay, so I guess what is AI is the first question, and then what is it doing at the moment in healthcare, um, and how do we make it work in the real world? What are the problems and the challenges that are facing us in actually deploying AI for benefit in the clinic? And this is often discussed about, but the risks to patients, is it safe? How can we make it safe? Um, and then looking to sort of the future, what is the future going to look like, and how are we going to use AI in healthcare? And I'll touch very briefly upon all of these things, but I think you know the exciting thing is that AI at the moment is such a new field, and new concept, kind of going forwards in terms of its applications into healthcare, and that really anything is possible, and people can kind of dream of these things. Um, and actually, in a few years' time, they may well be our day-to-day realities. So, I guess the question is, what is AI? What does it do? And what is that term that's so kind of usually flung about in places like media as well? Well, AI describes a wide range of things. Um, it's very simply any sort of computer processing or algorithm that is aiming to emulate tasks of a human brain. Not necessarily a specific task such as addition or multiplication, but more things that we would associate with kind of sentient intelligence. Um, this can include things like learning and asking questions, perceiving how does something make you feel, or how do you interpret something? A clinical example is, you in the clinic, you can perceive somebody who's in pain, you can perceive somebody who has a symptom, and then you can put those together in a learnt framework. And a lot of the kind of the difficulties of how we do that um, is what AI is trying to kind of capture through various different algorithms and approaches within that AI umbrella. And prediction is another important area that AI is perhaps more traditionally associated with. Um, a lot of the AI techniques stem from regression modeling and predictive modeling approaches. And so prediction is one of the key kind of things that goes into AI. And really, we talk about AI as something, we think about it as something that's only happened in the past couple of years, really. But actually, many of the algorithms that underlie what we would describe as AI today were actually come up with in the 1960s. So 19 in the 1960s and 1950s, really that was the first time that neural networks, this kind of approach to data kind of analysis and understanding data, were really kind of conceived. So building large models that are interconnected like neurons, that's what a neural network is. And that initial research took place well over 50 years ago. As time evolved, the things changed and neural networks were further refined. But it was quite a slow progress to become anything that resembles the AI we know of today. And really, that was all driven by the availability of computer processing power. And so in the early 2000s, graphics processing units or GPUs, these processors that had instead of in your computer you probably have used to. I remember having a very old computer when I was about 7 years old, and it had one whole processor core. But nowadays you might have 16 in your laptop. Um, but GPUs themselves have hundreds, if not thousands. So they can process thousands and thousands of bits of information in parallel at the same time. And this is essentially what underlies the process of a neural network, thousands and thousands of nodes within a network performing rapid calculations. And actually, the GPU did enable all of this AI stuff to start to happen. Fast forward to today, we have GPUs in our phones now. The kind of processors and microprocessors that are available to us is kind of getting infinitely more powerful. Um, and actually, that's then enabled things like ChatGPT, which is a large language model, and other kind of similar models to be able to ingest and analyze nearly the entirety of the internet, and certainly nearly every academic article that's been published. And that was then combined with kind of developments the in how we then do something called back propagation, so how we can teach models to learn from their mistakes and from themselves, and establish ground truth. So a bit of kind of the technical stuff has come forward with the processing power available, and that's kind of driven things like ChatGPT to now actually be able to function in a way that is usable. Um, this combination of large language model processing and deep learning being able to look back and actually learn. So it's come leaps and bounds, and actually we're now to the point where in clinical medicine we might be able to start using these. This is just an overview of one of the kind of the commonest types um, of artificial intelligence. It's a neural network. These are nodes and layers, as indicated by the diamonds. But essentially, what happens is that the algorithm takes an input. So in this case, it's a banana, and it's taught to recognize what's a banana, what's an apple, what's a pineapple, and then once you've built it, it goes through these images or these bits of data. You can plug anything into um, a neural network, and it decides based upon the trained features whether something is in this case, an apple or not an apple. Um, and it's quite a nice illustration of it. But these work really well. And this is the famous graphic card that has, well, this is what a graphics card looks like. And that's really the thing that has driven developments in AI so fast recently. Okay. So actually, if we think about our day-to-day job, I work in the NHS in the UK, and I think about, well, do I use AI at all? And I sat down last week and I thought, actually, I can't think of many places at all where AI is a routine thing that we do at the moment. But actually, when you scratch the surface of your interactions and the things that you do, underlying it, a lot of the new healthcare technologies have it already embedded in. So, for example, a CT scan. Um, a few years ago, CT scans, which usually have those sort of lines that go through them, appear a bit grainy. Particularly the rapid CT scans that are trying to capture things like arterial phases. And you can see that this is an example of how many CT scanners, modern CT scanners now do their processing. They take the raw data that comes from the detector, and it's reconstructed. This is on the left in the green, the kind of the traditional grainy image of a low dose CT. And actually, when you increase the radiation dose, you get a bit more resolution, because you get more slices, you get more definition. But actually, what you can do is by using an AI model that's in the background doing the computed bit of the CT, by training that algorithm to say, oh, what's the low dose like compared to the standard dose? How does that usually render in the standard dose format? you can do low dose CTs now that have the resolution and the actual diagnostic ability of those standard dose CTs. And this is something that's Canon in their scanners actively using at the moment. And it actually it looks really good, and it's very, very useful. Another thing that has been deployed in GP practices across the UK is something called medical scribing technology. One of the manufacturers is Heidi, but that essentially uses natural language processing and AI to kind of interpret clinicians' appointments. Essentially, the AI sits there, records the interaction, and will summarize the whole consultation for you. So people don't have to write medical notes, for example, and they can even generate referral letters from the information that's collected from the consultation, which is saving valuable time. And this is kind of really the start of kind of how it begins, and how we're going to start to feel this filtering through. At the moment, AI is doing very basic tasks or tasks that we can't kind of necessarily interact with or see. And medical scribing is considered a solved problem within the AI field. It's very straightforward, and it works reasonably well. And it also has that interface to be able to allow clinicians to interact and check things. But this is just the start. One of the things that is now starting to creep into practice is that AI systems are now being able to be deployed within electronic healthcare records. Traditionally, electronic healthcare records have been very kind of clunky, and the data structures and the way that people interact through a click and point interface has not been a particularly slick mechanism, and particularly with paper notes as well. It's impossible for an AI to very quickly kind of read paper notes and then summarize those. There's a lot of manual labor involved in that. But as the world shifts towards more electronic healthcare records, some of the companies are now starting to investigate how they could integrate this into their products. Possibly the company that's furthest ahead with this is the Epic EPR. It's quite kind of commonly used in the States and a few places in the UK and worldwide. But actually, Epic have now developed a medical records summarizer AI tool, which can go through kind of reams and reams and reams of clinic letters, clinical notes, laboratory tests, etc. And using NLP, quite a basic NLP algorithm, it'll go through and it'll summarize the whole medical record for clinicians, which is incredibly useful as a tool. So it's starting, but it's not fully there yet. And actually, the most exciting applications of AI are largely remaining research tools. There are some new developments first coming through, but one of the key things that is preventing the uptake of AI is these questions about how can we do it safely and what are the risks? Because at the moment, those remain fairly unquantifiable. And maybe the more pressing thing is who takes responsibility if something goes wrong? Can you, as a clinician, say actually, yeah, that you can't have an AI making a mistake and then that being attributed to you, because that's not you necessarily doing those things or doing those decisions. So where AI has that role is potentially supporting people and improving the utilization of time, but actually it's very difficult to know about decision making in this context. So one of the quite interesting things that we've been developing here in Edinburgh is thinking about how we can use AI in sort of very routine things to reduce things like follow-up appointments and to detect complications early. Now, one of the big complications of a midline laparotomy, for example, is wound infection or wound dehiscence. It's not something that we necessarily would monitor every patient for outside of hospital, but actually, if that complication happens, it's very important to know what's happening and also to initiate some prompt treatment in order to prevent a wound opening up further, for example, or to prevent infection from spreading. So one of the things we've been doing in Edinburgh is that we've been getting people to send in selfies of their abdominal wounds, and using some AI, the AI will kind of draw around where it thinks the wound is. It will compare the colors on it and say, actually, that's very red. That's an infected wound. There's pus coming out of that, and it will label those features. It will color them, and then it will generate a prediction based upon those features and say, actually, this person has a 2% chance of a wound infection, or this person has a 98% chance, etc. And prompt clinicians to then initiate either an antibiotic treatment or say, yes, you need to come in to have your wound opened up. Which is quite a nice application. We've got a couple of papers on that to do. So the next, and the way this works really is that it'll take that kind of wound image, it will then split it into its component channels. So looking at the amount of redness, the amount of greenness, the amount of blueness, it'll then tile those up and it'll split those down. And then based upon a trained model, it'll have a look and say, actually, that's a feature that's a wound clip, that's a suture, that's an open wound, that's an infected wound, and it'll assign a percentage to each of those features and say, we think this is this much, we think this is this much, we think this is this much. And quite often people have taken selfies of just their wound dressing, which is not very useful at all. But actually, the AI algorithm can pick that up. Again, one of the problems that we do have when training these models is that actually there's only a finite amount of wounds that we can reasonably process. So if we do, say, 500 laparotomies in a year, that's still only 500 images. And for anyone who's ever trained an AI model, you need lots and lots and lots and lots and lots of data in order to do it effectively and to get decent accuracy as well. So, and yeah, of those 500, maybe only kind of 5 to 10% of them will get an infection. So that's maybe 100 infections a year maximum that we're looking at. So how can we use that, and how can we, again, take into account differences in people's skin, differences in people's shapes of wound? How do we remove those sources of bias that an AI can look at and go, actually incorrectly attribute a feature to that? And one of the ways that is actually very useful is by image distortion. So preserving the features that look like an infection, like pus and exudate and redness. But actually, if you stretch that image, if you squash it up, if you make it fuzzy, those things don't matter, because you're not looking, when you're looking for a wound infection, you're not looking for the fuzziness of something. You're looking at actually the features inside that. Is it red? Is it angry? Is there pus coming out? And by doing that and distorting the image, then that takes away a lot of those confounding factors. And that's something that we've really found to be quite useful. Now looking at the cancer field as well, this is something that AI really is going to revolutionize. The problem here with AI is that it's unacceptable to miss a cancer and not have somebody take responsibility for that. So when we talk about the challenges to AI, particularly in the field of early cancer detection, that specificity on that model, that ability to be able to rule out cancer is the most important thing. So this is a nice article that was actually in Nature a couple of years ago, and very simple AI type algorithm using a deep learning neural network. Essentially, they wanted to compare how well this deep learning model did compared to an expert dermatologist. Gave it a load of pictures from very routine teledermatology appointments, and actually compared to the average dermatologist, which is indicated in this big green cross, and you can see that actually the sensitivity and specificity of the AI was higher, and there was a greater proportion of area under the curve, so kind of 0.95, 0.96, which is very good. But again, if AI can do something, it doesn't necessarily mean it should do. And who takes the responsibility for those small number of patients where that cancer has been missed, for example? Um, and that's maybe a good thought about what are we training these models to do and what are we training them towards? Because as these models are trained, you can optimize them for different parameters, including specificity. And some of the work we're doing in Edinburgh, we're looking at early cancer detection, and we're training models that are very, very, very specific, but they're not incredibly sensitive. But actually, when you think about the clinical application, we want them to not miss early cancers, not necessarily pick them up all that well. We just want to be able to risk stratify that group. And more usefully, in laparoscopic surgery, taking out somebody's gallbladder, a cholecystectomy, is actually a very kind of routine operation that's done all over the world. However, it's an operation that is not without risk, and there are some very important structures that damage to these structures just underneath the gallbladder into the liver can result in some pretty horrendous complications that are very kind of well described. And actually, it's you know, to the untrained eye and to many people across the world who do this operation, it's very easy to accidentally divide some of these structures, particularly if it's a difficult operation. So this is a lovely piece of work that's been done by the people in Strasbourg and Urcad in France, but they've got this amazing computer vision model that can identify features in kind of during laparoscopy. It can identify the grasper, for example. It can identify what's the gallbladder, what's going to be the cystic duct, where's the cystic artery going to be, and where actually the Kello's triangle dissection is going to be safest to do in order to achieve what's called a critical view of safety. And the kind of advantage of this sort of thing is that how it's envisaged to kind of work is that we'll have to have laparoscopic surgery, the signals have to go through into a television monitor anyway. So if you have this box or this kind of processing unit that you could attach the signal cable to, it could provide an overlay during your operation to say, this is where you should dissect, this is where you shouldn't dissect, these are the key structures to avoid. Again, it's all about actually how confident is that computer in making that assessment, and where do you put that threshold? All right. So, the risks of AI. We've touched upon some of the things. So this is a great example. What happens if the AI says, actually, this the common bile duct or the cystic artery, that's gallbladder, you should cut there. What happens if it says that, and who takes responsibility for it, and where do we quantify, where do we put a risk cutoff for that? So, as well as that sort of clinical kind of dilemma, there are other risks associated with it as well. So, confidentiality. One of the big problems with healthcare data, and quite rightly so, is it contains some very personal information to everybody. It can contain everything about somebody's life and all those things that people don't necessarily want to be out there in the world, let alone passing to corporations to develop large, complicated models from. Knowing what happens to your data is one of those key kind of tenets of medicine and surgery, if you will. Equipment, as models get more complicated and more powerful, you're really going to need some secure near patient processing power. You can't just kind of be wandering around with your iPhone and hoovering up other people's data into that. It needs to be thought about. And actually, Google, Amazon, Facebook, they've got all these huge computing centers that are there and very secure, but we can't necessarily in a healthcare system support that level of technology everywhere. It's got costs, it's got risks, it's got lots of layers of things that we need to unpick. Risks to patients, we've kind of covered a bit of that already, but how can we provide safety, and particularly the kind of the rare events that we may not be able to train a model accurately to pick up? And interpretation, how quite often in healthcare scenarios, um, there's a lot of, oh, I've not seen this before, or what do we do in this situation? People have to discuss it and then come up with a reason, debate, and rationale as to why that step needs to be done, or why that test needs to be done, or what's the next thing that this person needs in their best interests. And actually, can a computer do that? Can a computer weigh up different emotional, physical, social health needs very well for an individual? That certainly remains to be seen. One of the examples that I'd like to give you, though, and sort of close on this one because there's some exciting other speakers as well, is one of the problems that we've come across and how we've tried to address it in terms of confidentiality. So AI kind of incorporates all of these things: natural language processing, machine learning, deep learning, and there's certainly a bit of a crossover between all of them. Um, but natural language processing really kind of relies on how do we interpret the written word, and medical written words often have different meanings and different structures underlying them to the spoken word. So this is Cameron. He's one of our surgical trainees and a genius research fellow as well in Edinburgh. But he did for his PhD. He looked at do early onset gallstone disease, does that predict future cardiovascular risk and metabolic disease? And for this, to establish a cohort of patients with gallstones, we looked at the ultrasounds that we've done of gallbladders over the past 12 years, which was 180,000 people. We looked at all their reports, just written free text. And we also looked at 15,000 MRCP reports and just asked, can we pick up those people who had either incidental or symptomatic gallstones, and how can we create a cohort that we can then study and then also risk stratify, look to see if there's other features in that report as well. So this is a very typical and very simplified report that may be seen in that. So this report says gallstones were not seen in Cameron's gallbladder. They were seen in the duct. He has requested I send the result to his house, 12 Morningside Road, Edinburgh, EH10 4DB, on the 30th of November 2018. This is obviously not a real report, but it contains some very important features that we need to both clinically know about and also are important to Cameron in terms of his data and his confidentiality. It's got his address, it's got his when that result is going to be sent, and his name. So people can find out who this is and say, actually, we know that you've got gallstones, and healthcare data needs to be confidential. But in terms of how we can process that data and how natural language processing needs to be able to recognize it, just searching for the word gallstones is not enough, because actually here gallstones were not seen. So we've negated that, it's not there. And actually they weren't in the gallbladder, they were seen in the duct. So that's quite a complicated set of phrases that needs to kind of be addressed, not in the gallbladder, but they were in the duct. And there's a fabulous set of parsers that has been produced by Stanford, Stanford NLP parsers, which allow us to have a look at that and kind of understand it in more detail. So what we can do is, using this parsing library, is we can look and see whether certain things are disclosive. So, for example, a date could be disclosive, a number could be disclosive, a location could be disclosive, and a name such as Cameron, or the inference of that phrase containing a name. So the gallbladder belonging to Cameron. But using these NLP parser libraries, what we can do is we can assign a prediction to each word and say, we're pretty sure that that is going to be a disclosive piece of information. And then we can take that out. So that sentence, once we kind of sanitize it, would be gallstones were not seen in gallbladder, which is much more useful to us. Um, Now, again, these libraries allow us to then assign whether these words are going to be negations, whether they're subjugations, um, looking for the whole sentence structure in order to determine interpretability of that. And just by using the kind of the core things we're looking for example, the phrase gallstones, we can then identify that gallstones were not seen in the gallbladder, but were in the duct. Um, so we then developed this sort of analysis workflow where we set some very clear rules. So this isn't using any of the kind of deep learning or machine learning models at all. Just using kind of plain NLP. Reports were all sanitized, cleaned using these core NLP annotators. Um, and then things were kind of tokenized, split up, tagged, and annotated as we've seen before. And then our final annotated text undergoes negation analysis to see whether there is negation around the words gallstones, to see whether they have or they have not got gallstones. And we had a look at these results, and actually. By using these rule-based algorithms, we found that we could identify 98.1% of people with gallstones effectively. And it was pretty sensitive and specific at around 98 to 97%. So that was pretty good. But what does machine learning do? Um, Machine learning allows us to have much less pre-processing. NLP is quite labor intensive and requires people to check it lots. Whereas if you train a neural network to do it, neural network can look over the whole thing and go, actually, yes or no, and doesn't need to have as much anonymization going through it. So we did that and managed to, after kind of anonymization and cleaning, had 3 steps instead of the sort of 5 or 7. And it did produce similar accuracy at 98.4%, so slightly more accurate, but a lot more straightforward. But this goes to show that actually this whole process is an involved process, even to do a relatively simple task. And actually, when you think about the confidentiality in things like healthcare data and reports, it's really complicated, it's really complex, and we need to make sure that actually these algorithms can think about that using rules, whether they be ethical rules, whether they be workflow rules, is going to be really important in future. And one of the things that is starting to come to the fore now is how do we use ethics in AI? How do we, introduce models that are thinking about things like equity and equality, whereas a lot of the data that these can be generated on does contain inherent biases that are present within our world. So in summary, really, AI is going to play an increasingly important role in the future of healthcare and surgical care delivery. And there's already some kind of really important applications for these, and our group is doing loads of work into them, and so are other groups across the world. It's a really exciting time, and I could literally speak to you for hours about it. But it's already in use. It's going to become more common, but actually, there's an incredibly long way to go yet. And it's going to be very exciting as to what the future holds.
Thank you very much, Thomas. An excellent overview of AI and some of its basic applications in clinical practice. I thought we'll take a few questions here, and then we'll have a discussion towards the end as well, because while your concepts are fresh in our head, it may be that people would like to start discussing things up front. So I'm first going to say to the attendees, thank you very much for joining. I can see names from all around the world. I wish there were flags next to them and make it a lot more exciting for us. And if you want to ask a question, feel free to unmute and ask a question. Raise a hand is also fine, but if you're a bit shy, just type it in as well. I'm going to just kick off and talk a little bit to Thomas about some of the things he discussed, and we'll see how we get on. Thomas, excellent work. The wound infection stuff is your work, presumably with Ewan, is it or?
Yeah, so we've been running very similar models. We can't show the actual pictures, just because
Sure.
of patient things. But
Yeah, but
yes, we've done that.
my question more was why not go a step further? Like, I mean, I've been a surgeon what 26 years or so, and often when the wounds are opening and stuff, patients themselves know that something's not quite right and starting to smell a bit and discharge a little bit and stuff like that. Why not take a photo of a wound as soon as it's closed and get a probability score of the likelihood of a wound infection? I think that's a very achievable result. It may not be just the image that does it, though I don't think that's beyond AI's capability. But you might have to put in a diabetic 64-year-old with 3 centimeter subcutaneous fat, with a dirty or clean contaminated wound, and then take a picture. And I suspect the day will come when you could do something like that and straight away know the likelihood of a wound infection. Then you've actually got a sort of relatively intervenable scenario. What do you think of that sort of concept?
Absolutely. I think this sort of stuff is going to become more and more into the fore. So one of the other things that, you know, wound infection is a very kind of specific complication that actually there's many other complications too. So one of the things I've been kind of thinking about is actually, people coming for major surgery, and we've been giving them Fitbits or kind of monitoring devices, and people would routinely wear those in their day-to-day lives. So one of the things that actually, you might have this in future when if you're going for an operation, you might have a preoperative clinic where people say, actually, do you want to share your Fitbit or your personal exercise activity kind of information? Let's analyze your day. Let's analyze the rest of your healthcare records. And actually, people will eventually have a bit of paper that says this is your percentage chance of having a pulmonary embolism. This is your percentage chance of having X, Y, and Z complication. And I'm really excited to see what will happen and how that will change clinical decision making. When you, at the start of your operation, you say, well, actually, this person's got a 50% chance of having wound infection, is going to have a 20% risk of having a DVT after this operation. How is that going to then change the post-operative or the pre-operative interventions that you do in the decision making around that?
Hmm. Excellent. Yeah, that's really exciting stuff. I tell you a little bit about the background of what we're doing in Singapore, just kind of interest to the whole group. We've created an internal framework that is a supercomputer housed within the National University Hospital, and it's fully firewall protected. So we have the Epic system running at the top layer of this, and underneath that, there's deep learning, such that our my junior doctors can just say, discharge Mr. Lim, and click a button. And in fact, some of them are on this call now, and they'd probably be able to speak to this better than I can, but click a button and it goes right through the whole story and says he presented with this pain. The ultrasound showed this. He had a fever. Blood test showed that. He was taken to the operating room. The surgery note showed that. 3 days in hospital, etc., etc. And it's reading all that, and it's really at a very basic language model of GPT based, Chat GPT based language models and stuff. The next level to that is we're doing exactly what you just described, where we can just trawl for the whole country of 5 million, to take a look at, let's say, gallstones, and you can go straight into all the records at infinitum and process all that with the with the supercomputer, not superpower, that'd be even better, with the supercomputer, and be able to pull all those languages out and identify all those patients straight away. So it makes large data sets very achievable. Sort of, we're talking half an hour, 1 hour, and that's achievable. Is that the kind of thing that you think is the way to work around the sort of security elements and stuff like that? Or is there, because I know in the EU there's some other ways people are looking at security in healthcare and stuff like that. What are your thoughts about stuff like that?
Yeah, I have a lot of opinions on this, and it sounds like I need to come to Singapore. It sounds fabulous. So one of the way that there's lots and lots of competing thoughts about it. And I think one of the things that is going to be happening, particularly as the world becomes a bit more unstable, is that that data is going to become even more precious. And once it's out there, it's lost, and it can't come back. So thinking about how we do this in a safe way, and how we bring the power of data science to really and can deep learning to benefit people is important. Having big supercomputers in hospitals, I think, is just the way to go. Um, and being able to process that in real time, because actually, um, healthcare decisions are real time. Everything will be in real time, and having enough computing power to even process an image is really, really difficult. Um, and having that locally is going to, at the moment anyway, with our current kind of level of computing power, is the only way to do it. In Scotland, what we have safe havens, so we have essentially the same thing, but it's in kind of a box that is you can't connect it to the internet, it
Scottish
can't talk to things necessarily,
in a
and that's what
Scottish
we've been
subway.
doing.
In a Scottish
Yes,
subway.
exactly. Yes.
Um, Laura, Derek, did you want to chime in with some questions for Thomas while we're waiting for our participants to think about some questions?
What do you do if you feel there's a discrepancy between what the AI tool is telling you and what you think as a surgeon?
I think in that scenario, I think AI will, for the foreseeable future, the close future anyway, it's going to be something to support us. It's not going to be something that we kind of, will rely upon. Anyway, I think it'll be like, oh, I'm not sure as to that prediction. I don't think that's quite right. Let's, ask the consultant. Let's get the opinions in the room. Should that thing happen, yes or no? And that'll just be in the back of your mind that actually this AI thing is telling me that could be a potential, but going forward, you know, is it going to be? And it comes back to this thing: what are we designing these AI things to do? And the people in this room are going to be likely designing AI things. What is the acceptable risk of it? Are you asking something to say, is there cancer, yes or no? In which case, having something that says, yeah, there's cancer, but actually I can't rule it out is a bit useless. It still might be there. But or having a test that says, yeah, there's definitely no cancer here, but it could be there still. That's more useful and less risky. And the same thing goes for something that's telling you to cut a bile duct or to take out somebody's appendix. It's got to be designed with clinicians and patients in mind.
I just wonder, Derek, for that specific example, whether we would see the day when a
Thank you very
trainee
much.
where a trainee was doing a gallbladder operation and the AI said you're safe to cut, and the trainee's wondering, no, I shouldn't cut. Then you would think of doing an ICG or an intraoperative cholangiogram. So you'd augment your ability to increase your visualization of something that you may not have considered doing as routine. You'd add some layer of buttress because of the differential disagreement between AI and I mean I think that's what the next sort of 3 to 5 years is until the learning ability of these things are beyond human pattern recognition, I think. Um,
I think that's very wise. Yes, I think it should, at the very least, should give you pause for thought
yeah.
and maybe a second opinion, or as Len suggests, some other modality of safety.
Okay, I'm checking the question and answer box, and there isn't anything just there now. But Laura has been sat so patiently poised, so I'm just wondering whether we move on for now and we keep some ideas for Thomas. Thomas, will you be all right to join us till the end of the discussion?
Yes, I might need to pop off for clinic, but I'll do my best to stay.
Okay, great.